A very good afternoon to everyone. Myself, Dr. Nares Parajuli from Nepal. The next session would be about diabetic distress, combat hidden struggles of living with diabetes. And this is the SAFI's Symposium, South Asian Federation for Endocrine Societies. And to keep up with the time, I'd like to process with this session. And I'd like to invite Dr. Sanjay Kalra, who needs no introduction, is the president of SAFI's, consultant endocrinologist, Bharti Hospital, Karnal, India. Sir, we'd be privileged to have you on this stage as a panel of experts. I would like to invite Dr. Faria Afsana, who is consultant endocrinologist, assistant professor, Department of Endocrinology, BIRDEM General Hospital. Sanjay sir, please. Faria ma'am, would like to request you to be seated as a panel of experts. May I request Dr. Amena Moazzam Mirza from Pakistan, assistant professor of endocrinology, Department of Endocrinology and Metabolism Services Hospital, Lahore. Please, ma'am. I would like to request to be seated as a panel of experts. May I take this opportunity to invite from Maldives, Dr. Mohamed Siruhan, consultant physician and endocrinologist, Indira Gandhi Memorial Hospital, Male, Maldives. Sir, if you are around. I would also like to invite Dr. Dulani Kottahachchi, who is a known figure, a consultant endocrinologist and senior lecturer, Department of Physiology, Department of Medicine, University of Kelaniya. Madam, please, would like to have a seat. So I would like to invite Dr. Saila Sajid Sheikh, who is a consultant endocrinologist from India. Ma'am, she is a consultant endocrinologist, Safi Hospital, Reliance Hospital, India. Ma'am, would you like to have a seat? So this is the expert panel discussion, and today we'll be talking about diabetic distress. And I'd like to invite Sanjay sir to have a short introduction regarding this particular topic, which is a burning topic. Sir, please.
Good evening, everyone. When we treat diabetes, when the person comes to us with diabetes, it's not a glucose number that is coming into your clinic. It's a person, it's a human being, a man, a lady, a boy or a girl. And that is how we should view that person, that individual, as a human being. The person comes in with diabetes. Diabetes may be newly diagnosed. It may have been there for a long period of time. The patient may have had a new complication, a new comorbid condition, maybe a new drug that was started, or maybe a new intervention that has been suggested. That intervention can be insulin, it can be dialysis. And all these things put together create a lot of distress. They create a lot of distress in the person living with diabetes. We call this diabetes distress. Diabetes distress is different from depression. For depression, you need diagnostic criteria. So the patient will have depressive symptoms, but not necessarily meeting the criteria laid down in DSM-5 or in ICD-10. So to focus on this diabetes distress, what SAFI's did was, the South Asian Federation of Endocrine Societies, we launched our guidelines on diabetes distress in March 2023. And just earlier this month, they have been published in the Journal of Pakistan Medical Association. So a warm thank you to Professor Fatima Javed. Madam is the editor-in-chief of Journal of Pakistan Medical Association. For those of us who do not know Madam, Madam is now 86 years old. Madam continues to work as editor-in-chief, and she's an active editor-in-chief. So for people like me and for Dr. Shaila who think of retiring and resigning, so if Dr. Fatma Javed Madam is not retiring at 86, so we are also not allowed to retire. So see, I chose the right person. So Amena will also laugh. So thanks to Madam for having published this for us, and also thanks to the president of ISC, International Society of Endocrinology, that is Dr. Abbas Raza from Lahore in Pakistan, who spearheaded this. JPMA is free to access, free to download, so feel free to download this from the website. www.jpma.org.pk. PK is for Pakistan, jpma.org.pk, and it's something very pleasant to read. What the South Asian Federation says is, the SAFI says is that we need to detect distress in a timely manner, and then we need to intervene in a timely manner. So that's what we'll be speaking about today. And thank you to Dr. Nares, who's spearheading this discussion for us, and thank you everyone. Before we start the discussion, before we start our experts, get our experts to comment, perhaps we could have questions and comments from the audience. What kind of distress do you face in your clinic? Has there been any difficult case in the last week and the last month where you feel that the patient didn't need too much of biomedical support, the patient didn't need pharmacological support, the patient actually needed just psychological support, social support, just hand-holding, just a smile, just a statement, "Madam, I understand, I am with you." So any comments from the house, please, and then Dr. Naresh can continue.
Thank you, sir. We'd love to have you on your seat.
Yeah, thanks, Sanjay. Actually, I just, it comes to my mind, my consultation in the last week with one of these people, he simply is so overwhelmed, like he is, his sugars have actually not got very bad. His A1C, I think, had gone by about 0.3%, but he has not been able to manage his diabetes due to various, issues and so on. So he was very distressed, and again, acknowledging his issues, and as you say, support was the most important thing. We see these things every day.
Thank you, sir. Over the next 30 minutes or so, we'll be talking about these patients. We'll be talking about how to manage these patients and how the approach would be. So moving on, I'd like to invite Dr. Dulani Kottahachchi, madam, to have the presentation regarding defining diabetes distress. Do you have the presentation?
Thank you. So I'm presenting this on behalf of the Afghanistan team. So it was a collaborative effort, and so let's start with the introduction and how.
Number one, presentation.
So first, what we do is we'll define and we talk a bit about epidemiology of diabetes distress. So diabetes distress is a psychological state found in people with diabetes and their caregivers as well, which is unique, often hidden, and it's emotional burden and worries that a patient experiences when they are managing their kind of severe chronic diseases such as diabetes. So this state can cause significant emotional distress. However, it also fails to meet the diagnostic criteria for major depressive disorders as well. So in 2017, Standards of Medical Care in Diabetes, which published by the ADA, mentioned that we need to assess and manage diabetes distress to improve self-care and glycemic control, and also reduce cardiovascular risk and all-cause mortality. So it's important that we prescribe medications. Yes, we do that, but how many of us think about diabetes distress in our patients? So diabetes distress has been defined across domains relating to mainly 4 categories. One is diabetic regime, the monitoring of blood glucose, dietary control, and increase in physical activity can be challenging for some patients. And they might have interpersonal or relational issues referring to conflicts with carers, partners, and friends. And they can have an emotional burden as well, feeling demotivated, unsupported emotionally, misunderstood, and worrying about future complications. You must have patients saying, in what stage of my disease am I? Is it severe? Is it mild? So they're worrying about complications as well. So in diabetes distress, this is a schematic presentation where how it affects the patients. So burden of living with chronic disease, a fear of failing or keeping up with the diabetic care, fear, anger, and despair about living with diabetes, feeling of being controlled by diabetes, feeling not being supported by healthcare providers, that's us, social isolation or feeling, a lack of social support, and other quality of life issues as well. So, can we differentiate this between depression? So I'm not going to go through the whole list, but yes, we can differentiate, but it may coexist and co-occur together as well. But mainly diabetes distress is an effective response to diabetes morbidity and the burden of the disease, whereas in depression, it's a complex response and involves a range of other reactions dissimilar from the effective response. And there can be specific effective reactions which include worry, fear, guilt, sadness in diabetes distress, whereas response usually includes cognitive, affective, social, motivational disturbances in depression. And prevalence is more in diabetes distress compared to depression, so forth. So it has to be differentiated from depression. When talking about epidemiology of diabetes distress, worldwide it may affect as many as 40% of people diagnosed with diabetes. And so in community-based studies, they have revealed that it can occur up to 45% of people living with type 2 diabetes. And it's more frequent in younger people. We think, shorter duration, younger people have more diabetes distress compared to people who have lived with diabetes over years and older. And 20 to 40% of people living with type 1 diabetes experience elevated or severe diabetes distress. So cross-sectional descriptive studies in non-communicable disease clinics of a tertiary care medical center in India had reported 42% of their patients to have these symptoms. So you can see how prevalent these are. So these are some prevalence studies showing the distress across some studies. So I'll hand over to the next presenter.
Thank you, ma'am. We'd love to have you back in the seat as panel of expert. Now moving on and carrying it from here, regarding factors and symptoms of diabetic distress, I'd like to request Dr. Faria Afsana to further approach on the presentation.
Thank you, Dr. Nares. And this is, as we are discussing the diabetes distress, the next part is the important factor. What are the factors and symptoms we look for the diagnosing the diabetic distress? So the factors and the symptoms. And as we know that the main factor is the inadequacy and uncertainty about the treatment access and ability of the diabetes care for the patient's perspective, from the family and friends, and also sometimes from the caregivers. These are the main factors which causing the diabetes distress. From the patient perspective, sometimes at the time of diagnosis or throughout the period of diabetes journey, they feel overwhelmed with the demands of self-management and sometimes feel frustrated, fatigued and burnt out and difficult to manage in the self-monitoring and also the self-management. And the family and friends sometimes become over-enthusiastic about managing the patient's diabetes in the first few months of diagnosis and throughout the period, restricting many foods and maintaining special situations for the particular patients. And the main thing is the absence of conductive discussion with the patients and the family and the friends that worsen this diabetes distress. And regarding the healthcare physicians, the healthcare providers are driven by fear of diabetes complication from the very first day, and also the fear produces the behavior in healthcare professionals interfere the diabetes self-management also. And the common reaction is that the patient is non-compliant, that make the patient very much in distress, that their diabetes is not curing, and he become the distress in monitoring and management of diabetes. So what are the major sources of diabetes distress with type 1 diabetes? The main sources are powerlessness. The one of is powerlessness, a state of helplessness, because the individual, though in the adolescence or adults, may try to control several challenges and uncontrollable and different aspects of diabetes. There are some negative social perceptions, physical distress, and friends and family distress. Another important thing is hypoglycemia and fluctuation of diabetes distress, and they are very much fearful of experiencing hypoglycemia suddenly and how to overcome, become over-enthusiastic about the doses, lessen the doses of insulin, and become very much overwhelmed with the hyperglycemia that occur after a period of hypoglycemia. So the management distress is another issue, and feeling distress over not constant monitoring and one's blood glucose levels, and feeling of not being sufficiently considerable of diabetes care. And the last but not the least, the eating distress that is very much disastrous, and feeling distressed over unhealthy eating, restricts for few days and overcome the rules, and then again starts overeating. And not only the diet, but exercising is also not disciplined throughout that period of management of diabetes. And there are some precipitating factors that influences this diabetes distress. And these precipitating factors occur in different level of life, sometimes in change in life in different phases from adolescent to adulthood, sometimes in marriage. The patient sometimes discontinue insulin. Even in many of our patients, we get this while not to disclose the thing to that of the other groups that he is or she is in diabetes and taking insulin. And sometimes we get the patients with diabetic ketoacidosis even after 1 to 2 days of marriage. And the pregnancy, a transition of strict control, and the menopause, when there is a hormonal imbalance and there is some peaks and troughs of the hormones, which can also a diabetes distress. Some environmental factors also, change in job and change in environment daily working may precipitate diabetes distress. And the glycemic control and the complications, the acute, any event of hypoglycemia or hyperglycemia requiring hospital admission may increase the distress while managing and may act as a barrier in diabetes management. Change in the healthcare support from family. Suppose a person is having support from his daughter about the management and self-care, but she got married and separated from him, and he became in distress of managing diabetes by himself. And change in disease management regarding the investigation and the treatment change from, suppose from oral anti-diabetic to insulin, that is a very distressed condition in some patients also. So that risk of diabetes distress is higher during the period of change also. And as shown by Dr. Dulani also, there is a major change in diabetes distress and the major depressive illness also. And these are two studies in two different countries showing the factors for diabetes distress. One is published in Saudi Arabia, where shows the prolonged duration of diabetes, female gender, and the increased duration or increased interval between the 2 visits and presence of diabetes complication, and requirement of hospital admission and presence of acute and chronic complications are the factors which precipitates this distress. On the other hand, another study, cross-sectional study in Pakistan, shows that the rural background, poor educational status, poor monthly income, and frequency of administration of medication and adherence to the medical treatment, all these actually negatively impact the diabetes distress. So there are some differences between the major depressive illness and the diabetes distress. In the symptoms of major diabetes depressive disorder, and very similar to diabetes distress. And in the major depressive disorder, there are 5 or more symptoms that take over at least and may occur over 2 weeks of period, and the patient must exhibit either change in behavior, change in depressed mood, and other symptoms may include the lack of interest and pleasure, appetite change, insomnia, psychomotor agitation, and among all these symptoms, it must be present at least for 2 weeks, and 5 or more symptoms must be there to designate as major depressive illness. On the other hand, for the symptoms of diabetes distress, the single symptom may designate as diabetes distress. It may be unmotivated, burned out, overwhelmed, frustrated, angry, guilt, denial, whatever the symptom, it may be a presentation of diabetes distress. So the core symptoms are sense of inability to cope with the prescribed medication and lifestyle modification and monitoring, and fear of developing complication, both the acute and chronic complication, worry about healthcare, access and affordability, because in our country, in Bangladesh, these are not insurance paid, and all treatment costs must be borne by the patient himself or herself, and dissatisfaction with the social support, either in the family level, the friend level, community and workplace level. All these factors produces the symptoms of diabetes distress. That is all regarding the factors and symptoms. Let's move on to the next part.
Thank you, ma'am. Thank you for your insightful presentation on factors and symptoms. From there on, regarding the early detection, I myself will be talking about the next topic. Thank you, everyone. So, carrying it from here, for the detection part, over the next 5 minutes or so, I'll be talking about available validated tools for detection and screening of diabetes distress, recent evidences, and tools that help in therapeutic aspects. So these are the few validated screening tools, the popular being DDS-17 or 17-item diabetes distress, a scale which has, which especially focuses on 4 different domains, that is emotional stress, physician-related distress, regimen-related distress, and diabetes-related interpersonal distress. Apart from that, later on, for type 1 diabetic patients, type 1 DDS was formulated. And as you all know, diabetic distress also involves parents, partners, and other caretakers as well. So tools tools focusing on those caretakers were also developed. And then the other popular tool that is being used is PAID, that is problem in diabetes, problem areas in diabetes, which has different items like 25 and 1 item PAID tools. It can also be used, which specially focuses on the emotional concerns. Apart from that, SDHCA, which is summary of diabetes care, self-care activities, also has been formulated where the 16 items surveys have been focused on self-care activities, which especially involves diet, which is specific and general diet, exercise, glucose monitoring, apart from that, food care, and food care is also focused on that particular survey. At the same time, MDQ is the other tool, that is multidimensional diabetes questionnaire, where the social and cognitive aspects of diabetic patient is actually looked after. So in short, there are many tools where especially CEPHIS has especially recommended different tools like diabetic distress scale, which is a 17-item tool as I discussed earlier. At the same time, 2-item DDS scale is also being recommended. The 5-item PAID scale is also important tool that can be assessed. So this is a 17-item DDS questionnaire where the 17 items has been in fact studied and the severity is assessed providing different scores. And we all know DDS provides a quantitative assessment of degree of diabetic distress, but it is not designed in fact to identify specific weakness in coping skills. That's why to build upon the therapeutic interventions, a better tool for coping is required. And for that, a tool has been developed, that is glucocopper tool, which comprises of 6 common coping mechanisms. The negative ones being negativity and blame. The positive ones are acceptance, optimism, planning, and action. And to all these mechanisms, certain score is being given, and the negative score is subtracted from the positive scale score. And using this particular tool, many studies, especially one of the studies from Kalra et al., they have studied in antenatal women with diabetes and have correlated them with level of diabetes distress. It was found in this study that the greater duration of diabetes was related with lower optimism. At the same time, high SB1C was related with high negativity, and low scores for planning was there. Hence, it was found out to be an effective screening tool for dysfunctional coping skills in pregnancy when complicated by diabetes. Apart from that, if we see diabetic distress as a 6th sign, we have different tools to assess it promptly. In a very busy schedule, in a very busy OPD, we can use certain tools like DDS2, which can be used for screening of diabetic distress. At the same time, PHQ2, patient health questionnaire, can also be used for screening of depression, and glucocopper 2 can be used for screening of negative coping skills. In summary, detection of diabetes distress is recommended but not routinely practiced. Timely detection using validated tools is vital for diabetes distress and diabetic mellitus management. The 3 screening tools recommended by CEPHIS are 17-item DDS, PAID 5, type 1 DDS, and glucocopper tool is used or can be used for assessing coping skills. From here on, I'd like to request Dr. Sila Sheikh to carry out from here. Thank you so much.
At the onset, I would like to thank the organizers of Slendo and Kalra, sir, for making me a part of the CEPHIS meeting. And to be very honest, it would not be right if I didn't put it on record that the entire concept of diabetes distress has actually been conceptualized by Kalra, sir. So it's very, and I think the main reason why, we are talking about this entire concept is because conventionally when we look at our patient, as was just told to you in the beginning, we talk in terms of numbers. We've not been trained, or we do not train ourselves to understand that we need to look at patients beyond numbers. As long as our numbers are good, we are pretty happy with the patient. It's only when the numbers go wrong that we are unhappy. As a clinician, you feel cornered. Oh my God, it doesn't look good on paper. We're not realizing that there's so much more to the patient. We talk in terms of, SMART goals. We talk in terms of keeping the patient at center of care. But at the same time, what we do not realize is that as a disorder, this disorder causes a lot of fatigue. And when I'm talking about fatigue, fatigue by the English dictionary means exhaustion. So, exhaustion, physical and mental exhaustion sounds so dramatic. Imagine being exhausted by the diagnosis, by coping up with a problem every day. But the fact remains that when you're talking about diabetes fatigue syndrome, it's multifactorial. It implies easy fatigability, which is going to be physical, mental, sexual, and it is going to influence your daily activity. And when it influences daily activity, it is, of course, going to influence your quality of living. And on the contrary, this can be a very, very important harbinger of maybe other comorbidities, maybe other complications. It could be just a harbinger of intense psychological, medical, metabolic, endocrine, or acute or chronic complications. It is the irony of the situation, it is bidirectional. So sometimes it may be very difficult to really realize whether it is the hyperglycemia which is causing the DFS, or the DFS is actually responsible for the hyperglycemia. It's something like whether the chicken came first or the egg, with a number of, exact pathophysiology is still not very clear. Some of the biochemical pathways which have been implied are up over here. But in the interest of time, when I talk about the causes, which I think we really need to be more aware of, lifestyle related, one of the very important parameters which we are increasingly becoming aware of is, of course, sleep related. The rest is up there. Diet related, I think it's very important, especially in our South Asian countries, to realize that we are protein deficient. Though we think that, when you look at the questionnaires and you think your patients perceive that they are protein sufficient, but actually the protein diets are really abysmal, and that's somewhere where we really need a lot of work to do. A number of diet fads. My patients have begun to love this concept of intermittent fasting, in restricted time fasting, and all kinds of fads, which, we saw in the previous session. I think the social media does a more, intensive job than us. And you have patients coming to with all these kinds of diets. And when you're looking at only numbers, often we tend to overlook other conditions like maybe anemia, maybe hypothyroidism, maybe as something as simple as vitamin D deficiency, which could be contributing to the fatigue. As far as endocrine causes are concerned, you've heard it all. You've heard about the glycemic variability, the complications of diabetes. What we do not sometimes pay attention to is that these patients can also be at a higher risk for other endocrine causes which could be causing the fatigue. And of course, statins. Statins, the reason I've highlighted it up over here is because that's a very, very common cause of fatigue which we need to keep in mind. There's no clear-cut relationship, to be honest, between glucose levels. Studies show there's a relationship between fasting but not HbA1c. The excursions affect fatigue levels, but all the studies show that women are influenced by fatigue more than men. So is there some special way we can approach it? This is up over here. You look at all the parameters, because when you're talking about fatigue and talking about analyzing it absolutely in a scientific way, you need to look at it all, whether it's lifestyle, psychological, glycemic status, or comorbidities. And then as an astute clinician, which you all are out here, you would go about diagnosing diabetic fatigue. Some special conditions I'll quickly run through in the next 1 minute. Ma'am already has spoken to you about diabetes-related distress in children with type 1 diabetes. We know, but more than the children, what I've realized is the parents get very distressed. And at that point of time, a lot of empathy is to be put in place, because the fact remains, I mean, my observation has been that when the child is diagnosed with diabetes, maybe their children not that aware. The problems we have with our type 1 diabetics is more when they become adolescents, you know. When they're adolescents, that's when my problems start. My problems are quite sorted out. I mean, I'm dealing more with parents than with children when they're diagnosed young. But the moment I have an adolescent, you know, kid coming into me with all the hormones and all the problems that they're dealing with adulting, add diabetes to it, and you really have a big issue out here. Young adults, again, very big issues, especially related to marriages, related to relationships, related to work, related to coping mechanisms, related to costs of their medicines, whether they really want to, the issues about with all kinds of fads, whether they really want to go off the insulin. There are lots of things which come up at this age. And I think somewhere with our busy clinics, we are often unable to really live up to what the requirements are. Marriage, ma'am spoke to you about. In our countries, we face a very big problem, and as ma'am said, can end up with a lot of problems. Lot of marital challenges, to the point of time, sometimes you're also worried when somebody comes to you and asks you, ma'am, this person has come to you and my daughter's, somebody's come for a marriage alliance and he's a diabetic. I mean, what would your advice be? And that really creates a lot of issues for you. And when I look at MACE, ma'am also spoke about the GDM issue. Yes, diabetes distress, the paper which we have just heard from Dr. Naresh. Work-related issues, we know, though all the guidelines say that diabetes cannot be a reason for unemployment, but the fact remains that when you say diabetes, there's always hesitancy in the employer's mind whether the person should be employed. Elderly, a different story completely. Geriatric diabetes by itself has become a very big issue. Our patients are increasingly living alone, so support systems, insulins, all that becomes a very, very big issue. But the biggest issue, I think, which we face in our country at least, is distress related to food. Even after 10 years, my patient will still sit in front of me and ask me, but madam, what do I eat? It is something like, without asking that most important question, nobody can go out of the consultation. It is a repetitive issue that, because food is something so close to your heart. I mean, you associate it with everything in life. So I think that's another area which requires a lot of healthy living. So of course, ask your patients, talk to them, understand them, diagnose them right, and once you've diagnosed them right, treat them, because you might just not realize what you're missing when you're just overlooking diabetes fatigue. Thank you very, very much.
Thank you, ma'am. Thank you so much for excellent talk. And I would like to request you to join the team of experts. From here on, I'd like to request Dr. Mohamed Siruhan to talk about the management part. Thank you, sir.
First of all, thank you, Slendo, for inviting me to be part of this upcoming area in diabetes management for us clinicians. And thank you, Dr. Sanjay, sir, for putting a lot of focus in this surface region. So I think the part of the problem with diabetes distress management is also because it also creates a lot of distress, not only the patient and also for the clinician as well. We are also distressed how to deal with the distress of diabetes. So for this, we need to gain certain soft skills in managing diabetes distress. So it may be corrected by choosing improving the self-perception about diabetes, improving the coping skills, minimizing the burden that need to be coped with, and involving other partners in coping. And you know that for many patients, the diagnosis of diabetes itself is a lot to digest. So they may be in denial. They may be, sometimes, let's say for HbA1c of 12, we may be somebody with osmotic symptoms. We may be actually advising them to start insulin. That is from a physician's perspective. But for a patient perspective, they may be actually asking, I really have diabetes? Doctor, do you think I need to repeat this test multiple times? So they may go doctor shopping, first of all, to even digest the diagnosis. So when we meet the patient, the doctor's plan and the patient's thinking may be very, very malaligned. That's the first thing I face. So this can come at diagnosis, at various stages of treatment, right? When we start insulin, and also as a lot of us are aware that diagnosing diabetes in a very small child can create a lot of distress among the family as well. So a lot of changes has to be brought. But we have to actually break this change into bits, and we have to prioritize the changes. So you don't have to teach them like exactly, like on the first visit, we should not be teaching them the whole textbook of diabetes and like the diet, exercise, everything. So initially what needs to be done in regard to the diagnosis, why you need to start treatment and what are the treatments available and what you think is the best treatment at the beginning is very important. And we also need to use of resources which can be human, like you as a busy clinician, you may involve like the diabetes educator team to deal with this as well. Optimizing coping skills, so acceptance, optimism, planning and action. Strengthening self-care is very important because you may be seeing the patients once in 3 months, one in 6 months, in some countries once in 8 months and maybe 12 months. But during that, every day the patient needs to be, to safeguard their diabetes. They need to follow the diet, they need to follow the physical activity. And for this, I think we should put the responsibility on the patient. So we have to convince the patient or the family the importance of this. It's not something that they are doing for the clinician, right, to improve the numbers. So we have to educate and empower the patient to improve their self-strengthening capabilities. And of course, the healthcare professionals, family, community, and the healthcare system is very important because after a diagnosis of diabetes makes, before the patient reaches the home, at least in my country, they will be talking to other people, their friends and family, and then if they meet 10 people, at least 3 or 4 people will say, don't take treatment. Because somebody was diagnosed with diabetes, he never took treatment, now he's okay. So this is it's very challenging actually because there's a lot of community pressure, which unfortunately most of the time is actually negative, unfortunately. So I do address these things when I see the patient for the first time. I say there's a lot of negative ideas people may instill in your mind, so be prepared for this. So this is very, very important to address these issues for ideal patient management. So it has to be highly individualized. There's no like one size fits all, right? So it has to be individualized, and this requires a lot of skills from clinician's perspective as well, because this is a two-way communication. First, you have to listen, then only you can actually address the problem, what he may be facing. If your priority is only HbA1c or LDL goal, it may not work out for some patients. And so you have to listen to the patient and address their issues. Otherwise, they may be not satisfied with you and they may go for doctor shopping, on a doctor shopping spree, which may not actually be helpful. So it has to be patient-oriented approach, but physicians need to understand and improve some soft skills. So first one is confidence. So you as a physician, we as a physician has to be have a good scientific knowledge to address diabetes as such, and it has to be we have to be accessible with authenticity. So which means the patient should understand that you are genuine and you can be trusted and you're honest, and the care provider should be able to convey his humanness and concern for the patient. And it has to be reciprocal, and which of course depend on the culture, the religion, the gender, the age of the patient as well. And you have to have express empathy. So the patient or their family member should understand that you are empathetic towards their situation, whatever the situation it is. new diagnosis or starting new treatment, etc. And it has to be straightforward and simplicity, and it has to be conveyed in a manner the patient can digest. So it has to be based on their intelligence level and their emotional situation as well. So these are some of the motivational interviewing tools, like water is one motivational interviewing tool, so which involves a warm welcome, ask and assess, again, two-way communication to tell the truth, okay? So you may have to use some analogies for this, and you have to explain with empathy, and you have to reassure and return. And always discuss with the patient whenever we are making changes to their treatment, so they feel that they also participated in this. So you give them choices. If this is not possible, what to be done next? So it can improve compliance. So diabetes distress has actually shown to improve HbA1c. I mean, especially in terms of physician's empathy in this domain, improve LDL cholesterol, and in fact there's a study which showed it can reduce mortality as well. So this is a very, very important aspect we all physicians should keep in mind. And this is a 5I strategy as an approach to diabetes distress. So initiate discussion, identify and degree and source of diabetes distress. Here a lot of my colleagues speakers have covered all these areas, how to diagnose it, inform minimizing diabetes distress, incorporate healthy coping skills, improve the quality of diabetes care and support. So in the interest of time, I'll just shorten my presentation. So you have to change their negative coping skills to positive coping skills, so which can involve the family and the physicians as well. This is another approach to deal with coping skills. This is assess coping skills, explain and eliminate the negative skills, introduce and internalize positive skills, observe changes regularly on routine visits, and understand and upgrade the patient's health-related behavior. This is acronym for AEIU approach. Thank you very much.
Thank you, sir. Thank you for excellent talk. Now, in the interest of time, would be moving forward, I'd like to welcome Dr. Amena Moazzam, Madam, for next topic, which is capacity building.
Good evening, ladies and gentlemen. I would like to thank the organizing committee of Slendo for the invitation to talk on such an important and unspoken topic, at least in our part of the world, diabetes distress. I would be talking about the management, the long-term management of diabetes distress. As already discussed, the management basically comprises of early diagnosis, good communication, and counseling skills. But I would like to stress here that it is a highly specialized field, and we as healthcare professionals should develop certain skills beside the soft ones to address this problem, such as its awareness, the screening, early diagnosis, and the ability to differentiate it from other causes of depression, offer it care, and timely referral to the right person is very important. Thus, capacity building provides us with a collaborative, interspeciality approach towards the screening and management of diabetes distress. But what is capacity building? Any idea? Anyone would like to volunteer? It is a process of strengthening an individual or an organization's ability to effectively carry out their function, achieve their objectives, and adapt to the changing environment. It involves not only developing, but enhancing the skills, knowledge, resources, and infrastructure to improve the performance and achieve the outcomes. So why is it so important? Why are we discussing it here? Why? Especially in diabetes care programs to attain sustained improvement in patient care. The load of diabetes is increasing day by day, and it has a great load on our present healthcare system. Thus, to reduce morbidity and mortality associated with the disease, capacity building is the only tool. So who are the people involved? Who are the stakeholders? Who are at the most risk? It's the patients. And we, as the healthcare professionals, should ensure that their diabetes literacy is maintained. Their family, their caregivers should be screened for depression. The society should be free of public health issues. We ourselves, we should prevent compassion fatigue and burnout. And also we should ensure that the resources that are being available by the healthcare system is used efficiently. So it is not only the individual or the healthcare system, it is the community, the policy makers, the environment, the family, everyone in combination go together to bring about this effect. Thus, the clinician's awareness of the person's mental health is of utmost importance. So whenever we encounter a patient, there are certain red flag signs that should be in our mind. What are those? Evidence of depressed mood, low BMI, reluctance to start insulin. As a result, there is suboptimal persistent glycemic control leading to hospitalizations. So whenever you encounter such a patient, please screen this patient for diabetes distress. Acknowledge his or her emotional response. Assess his distorted beliefs, formulate a plan, and please keep that patient in your follow-up. And it is stressed that diabetes distress should be incorporated in our daily comprehensive clinical practice. And this is only possible if we have a good patient-physician relationship, not otherwise. The patient will not disclose to you. This brings us to another very important topic, which is patient-centered care, which has been in the air for a very long time, in which an individual's specific health needs and desired health outcomes are the driving force behind all decisions. And he or she is actually a partner to the healthcare personnel, and his personal, emotional, mental health is taken care of besides the physical health. As you can see, there is a lot of partnership, information sharing, communication, and most of all, mutual respect amongst all to bring about the effective patient-centered care. Just to stress once more, these are the elements of effective patient-centered care. I'm sorry if you can't read the slides. The patient comfort, his mental health is of utmost importance. The family, the caregivers should be involved in the decision-making. The patient's goals should match the mission of the healthcare profession. And it is an integrated collaborative program. It involves not only the patient and the healthcare service, the doctor, it involves the community, the policymakers, the family, the peers. All people work together to bring about effective patient-centered care. The next stakeholders are the family and the caregivers. Since they are the people dealing with the patient 24 hours, they need to be focused. Therapy is needed to reduce their mental stress, to reduce the conflict between the family members. There are many therapies, one of which I've mentioned here is behavioral family system therapy for diabetes, which is a flexible monthly component intervention targeting family. It's thought to be very effective. We, the healthcare professionals, should also be trained in psychological intervention involving coping skills to bring about patient satisfaction and reduce complication. It is an evidence-based that those health professions who are trained give better results. We could run certain counseling techniques, those techniques which are structured, and it is seen that they prove to be not only cost-effective, but time-effective, since most of our primary care physicians are very busy. So they need a structure, a technique, which is also cost and time-effective to bring out beneficial effects. The educational material, I would like to stress here, should also be evidence-based, but tailored to our needs. The educational material which is used in our diabetes care program, though it is used for the doctors, nursing, patient, family, whatever, it should be evidence-based and tailored to our needs. So to conclude, capacity building is important for long-term sustainable improvement of patient care. It reduces morbidity, mortality, and thus the burden on the healthcare system. I would like to take few more moments of your precious time just to show you a practical implementation of what we've already discussed. Ladies and gentlemen, this is the Diabetes Management Center, Services Institute of Medical Sciences, Lahore, Pakistan. It is a multidisciplinary, state-of-art tertiary care center, and it caters to more than 200 diabetic and endocrine patients per day. It is equipped, we have all the latest machines for screening complications of diabetes, as you can see, periscan, nerve conduction study, retinal scan, HR-MAT, bone densitometer, all operated by well-trained personnel, both doctors, nurses, paramedical staff. We are actively involved not only in training our doctors, but also doctors from all over the province of Punjab. One other thing is that the system is that the data is power nowadays. Why is it power? Because it provides us with knowledge about need of tasks. What is the task of today? The rising burden of diabetes. We need a program for its surveillance. What better than an EMR? So most patients that visit our center, their data, their biodata, their history, examination, prescription is all entered in our EMR, easily available for us to assess at any time. We also provide telemedicine. It started during the era of COVID, and we are still continuing with it. The government provides us with insulin and glucose strips. These are just snapshots of all the workshop capacity building attempts that we've done regarding the nurses, doctors, gynecologists. We've reached out to the community, both urban and rural areas. The government, we've targeted the colleges, universities, offices. This is the rural area. As you can see, it has not been an easy task, but it has been made possible through our team. This is the mobile health unit surveillance team of our hospital. It comprises of a very well-trained team. And this is the mobile bus that we have. It is fully equipped with all the instruments for screening. We've also run certain sessions regarding Ramzan diabetes, physical activity, and dose-size activities. We've run a workshop for type 1 adolescent diabetic patients in which we screened them for diabetes distress, and they underwent counseling, both group and individual. We've also trained them for research. And no capacity building is possible without QI improvement projects. These are few to name. Once again, ladies and gentlemen, I would stress upon the introduction of capacity building in diabetes care program, which is essential for sustained improvement in patient care to reduce the morbidity and mortality associated with the disease. And it is only possible if the doctor spends time with the patient and educates him. And that, once again, is only possible if we all, that is the doctor, the patient, the family, those who are making the policy, are at one page, and we decide to do something about it. And I think this is the right time. Thank you.
Thank you so much, ma'am. Thank you for your insightful presentation. And now on, last but not the least, one of the highlights of today's session, that is SEFI's recommendation and responsibilities. I'd like to welcome Dr. Dulani Kottahachchi for the presentation.
So we have come to the end of the session of diabetes distress. So as a society, South Asian Federation of Endocrinologists, so this is what we recommend, how we should deal with diabetes distress. And we have divided for awareness for healthcare professionals and for patients separately. For healthcare professionals to be aware of diabetes distress, we need to have formal training in psychological interventions involving coping and counseling for improved patient satisfaction, that is to improve the distress, and psychological reactions and coping mechanisms which operate at the time of diagnosis of diabetes and continue all through management, and training in specific courses associated with teaching and counseling techniques such as effective patient teaching and problem solving, SWOT analysis and cares, and what approach which we discussed to involve patients actively, ensure provider-patient bonding and improve therapeutic outcomes. And for patients, diabetes education is very important using interactive modules we've discussed so far, such as diabetes literacy and numeracy education toolkit. And we should also promote self-awareness tools such as Johari window in patients with diabetes to ensure his knowledge about themselves that will aid in the better handling of one's emotions and personal issues, which will further boost one's self-esteem. So we should promote this in our patients. And creation of country-specific interactive tools where most of our patients might be with low health literacy and numeracy. So we need to be country-specific as well. For preventive measures, we need to be in combination with educational support. Family therapy should be recommended, and explore the role of family support and family functioning in implementing these family-oriented programs are very important. How can we educate our patients? With group discussions are very important. In patients with low health literacy and numeracy, as I said, maybe facilitated using interactive modules. Therapeutic patient education through a patient-centered approach is very important. And healthcare professionals should receive formal training in cognitive behavior therapy as well. That is to give this program to the patients. So educational programs should include the coping skills. Sorry, this is the same slide, sorry. The diagnosis, training of general practitioners and physicians in the identification and management of psychiatric comorbidities in rural and urban areas that is recommending. We are recommending that. And from the Indian perspective, consider self-perception of health questionnaire, WHO-5, PAGE, and other self-diabetes specific questionnaires available in local languages. That's suitable tools. And when you've identified diabetes distress, healthcare professionals should explain the link between these and poorer diabetes control so patients are aware of it. And assessment of patients' psychological and social situation must be part of diabetes managing using reliable, validated tools. So we should learn how to use these tools in our patients. And finally, the management, as we discussed now, CBT should be recommended either alone in combination with other strategies to these patients, and long-term motivational therapy with suitable follow-ups recommended. And therapy should be individualized and it's recommended in children, adolescents, for improvement in behaviors and adherence in adults for dietary behavior as well. Group-based counseling programs in conjunction with psychological counseling, CBT, behavior family system therapy, diabetes is very important. And we need greater social support, patient empowerment, and supporting coping skills that must be considered among women with diabetes as well. And we should also promote family physicians to encourage patients with diabetes to engage, integrate positive coping skills and de-learn negative coping mechanisms. So we should empower them. And finally, therapy to improve resilience resources and coping strategies of patients is recommended in patients with difficulty in adjustment with treatment and lifestyle modification. So these recommendations are laid down to help all of us to manage these patients with diabetes distress. As Dr. Sanjay said, it is now published. You can go through the whole guideline. It was a comprehensive workup through the Safis group led by Dr. Abbas. And we are sorry he couldn't be here. He would have been happy to be here and present this to you as well. And thank you very much.
Thank you so much, ma'am. Thank you for a nice presentation. Since we are running out of time, can we take a question, maybe?
I just wanted to, first of all, congratulate all of you for, first of all, coming together. I think it's an excellent example for everyone, no matter what field you're in. I'm taking lessons for women with polycystic ovarian syndrome, for example, and I think it's a great exemplar for how we should manage our patients. I had a question about how consistently you can deliver this and the resources from the healthcare system, how they would compare to the resources for pharmacological interventions. So in the UK where I work, it's a very sad thing to say, but it's sometimes cheaper and more consistent to give drugs than to give these behavioral interventions. So I just would like to know your thoughts.
That's a very valid question. if you feel that if you're going to divide things into buckets, that a behavioral intervention has to be given by a clinical psychologist, then it becomes expensive. It becomes absolutely impractical for South Asia. However, if we internalize what is written in this document and we make it part and parcel of our, first of all, our belief, that's number one. So we believe that this is important. Second, our thoughts. We think that this is important. Then automatically the third and fourth points become quite easy. The third is your language. So whenever you speak in the OPD, whenever you listen, whenever you speak, whenever you converse with the patient, just be sensitive to the red flag symptoms, signs of diabetes distress. The symptom may be the patient is saying that I am unhappy at home. The sign may be the patient is fidgeting around. The adolescent, Dr. Shaila said, the adolescent is looking left, right, everywhere except at you. Or you see that till today the glucose levels were fine. Now suddenly the HbA1c has risen and there is no obvious biomedical cause. There's no infection, no inflammation, no invasion, no iatrogenic issue. So if we integrate this, then it becomes part and parcel. So whatever work you are doing in the clinic, you will continue doing the same. It's just that you will always inquire at the beginning and at the end of every interaction, all fine at home, any psychological issue, any social issue. And there are many polite ways of doing that. So that is the words and the action. So let me repeat again. First, our beliefs and thoughts, Then secondly, our words and our actions in the OPD. If they are all attuned with this, automatically things are fine. No extra resources required.
Thank you, and congratulations to all of you again. Thank you.
Thank you, sir. Thank you, sir. Now, sir, please.
Yeah. I think thank you very much for all of you to putting together all this information. I think we should have just a suggestion, a common, questionnaire to be adopted in all the countries and to be translated properly and validated in our own, our set of countries. And then we could sort of try out in our clinics. Probably have a sort of a workshop to train our medical officers and who are attending to the patients. And have you sort of, Sanjay, tried there? How long does it take? Like you said, 15 minutes. That's about the maximum that we can take for a patient. Probably we might have to have a distress separate clinic, evening hours, because otherwise we won't be able to clear our crowd, 400 patients for a day. And I mean, that itself is a distress, and the doctors also have a distress, clearing the crowd. And you have to get their pharmacy will close at a particular time if you take. So we have to think how we can practically do it actually in the region with our patient numbers.
So it's part and parcel of my work at least, and I speak on Dr. Shaila's behalf. It is part and parcel of her work as well. So when you greet the patient, right from that word onwards until the time when you say goodbye to the patient, this is integrated into everything that you're doing. It gets integrated into history taking. I use the glucocopper. That is something we can translate into all languages and use. So that is one thing. Point taken about training, that is valid. Maybe 2 topics for next year's SLCE, SlendoCon. First would be creating happiness in the diabetes care clinic. How do you remain happy throughout the day? And second would be creating an illusion of time. You have only 3 minutes or 5 minutes with the patient, but how do you converse with him or her in a way that he or she goes back thinking that, sir or madam has spent half an hour with me. So I think these will be 2 specific topics. Workshop. Yeah. Yes. We can do a workshop on these 2 topics, how to create happiness and how to create an illusion of time. And workshop mode is the best, like lecture mode will not be good. Yes. Yeah, so we do a workshop and we include this as well in it. That's a very good point. Is next year's SlenderCon team is here? Yeah, so we can request them.
So can I just add something? I think if you can train the entire paramedical team also around you, that makes a very big difference. One of the things which was said is right from the first point of contact your patient has in your clinic. If the entire team is, in that, as sir is saying, that happy mode, I mean, where they believe that, the person who's come in has to go out with the feeling that he or she is very important, I think your job is done.
Yeah, actually we have trained, as you know, over the last 4 or 5 years, about 1,200 diabetes educator nurses. I was thinking we should have incorporated. So actually during their training, we had almost like a 3-hour workshop on communication skills, but it was not targeted like this. We got a non-medical expert to, teach them empathy and how to tackle with patients, difficult situations, all that, but it was not targeted like that. So that's why I was thinking a large workshop where we pilot one, and then we train the trainers, few people here, and then we can propagate to the whole.
Sir, if I can just add something. 6 months back, we had a team coming in to analyze our staff, and when they saw the screens, they realized the staff did everything else but didn't smile. And because they didn't smile at the patient still felt that they were sort of, so we are teaching them the other skills, but we're really not teaching them those very, small things which really matter. It may just be a touch, for example.
So thank you, sir. And thank you all the respected experts for having such a nice presentation and a lively discussion. This is just the beginning. We believe we will walk through it as sir suggested. Thank you, sir. Thank you, everyone.
Thanks, Naresh. And thanks for backing up at the last moment. Thank you.